$1,000 exam. Once upon a time, there were two buckets in the chiropractic world, one for imaging and one for treatment. Now there's only one bucket. If you, in the patient's insurance plan, there's a $1,500 bucket and you spend $1,000 for imaging, how much is left? Not much, $500. Okay, simple. So I didn't have to worry about this because I didn't have, there were very few MRIs when I graduated. You now have that responsibility. You can send a script. I want an MRI. Why? To rule out pars defect. Where's the pars? Where's the pars of the neck of the Scotty dog?
Oh, it's at the lamina.
At the lamina.
Like, at the it's the
Between
collar.
The pars between the facet
Oh,
joints.
yeah.
The region between the facet joints, or the pars intern between the articular processes. And when we get that, we have spondylolisthesis. Okay, is that important? Yes. There's lots of cases of spondylos. Well, they have to be detected first. So as you said, rule out pars defect to exclude spondylo. The imaging center understands that. When it gets to the doctor, the radiologist, he understands that. He now knows that you know. So I'm thinking, okay, how do we get this across? So what I had to do? You only have 7 courses in radiology. I had to rob something to show you advanced imaging. Okay? This is the introduction into advanced imaging. Because when you graduate, the first thing you do is, I can't wait to get my hands on the script, rule out spondylolisthesis. Well, wait a minute. Let's do it in the appropriate situation. So if you have a 7-year-old gymnast who is hyperextending, would that be an appropriate? Yes. You're making good clinical decisions based on your framework of plain films, nuclear medicine studies, CT scans, MRI studies, and now diagnostic ultrasound. You're not expected to be a specialist in those areas. You're supposed to be a generalist in a lot of different areas, but make good clinical decisions. That's what this is all about. It's an introduction. And we build on that framework every semester we get together. So next semester when we do shoulders, x-rays, I'll show you shoulder MRIs. By the time you get to National Board Part 3, you'll say, enough already. Just give me the exam, we can do this. Okay? All right, the first one is a nuclear medicine study or a bone scan. All right? And this is out of the textbook, and if I did this correctly, this is the 3rd edition. This is the 3rd edition if you want to know more about it. So you go to the hospital, they build a radiopharmaceutical, an agent that has to be injected into your system. And it goes through these phases. The important one to you, the clinician, is this delayed phase, okay, 2 to 4 hours post-injection. Now, you've been injected, and this radiopharmaceutical is going throughout your system, and there's this big Geiger counter-like plate that is detecting signals that comes off from this nuclear medicine isotope. Okay? You've been lit up, if you want. The nice thing about the radiopharmaceutical is it has a half-life of 6 hours. So if you follow their instructions and drink lots of water, it's excreted out of your system 6 hours later and it's done. What they're hoping to gather is this information. What is it? It's a skeleton with a bunch of black dots, right? Okay, those black dots are called hotspots. This is where the radiopharmaceutical gathers. It's very, very sensitive to abnormal disease processes. But it doesn't tell you what it is. It just says there's a hotspot. Okay? So and this is my foot exam. Which foot is this?
The left.
Left. Is it in the toe or is it in the calcaneus?
Calcaneus.
Calcaneus. So the classic example is, I decide I'm going to do a mini triathlon or a mini marathon. I start running. I get heel pain. You take your plain films. You can't see anything. What am I conjuring up? What type of fracture? Stress fracture. My heel hurts. I can't see anything on the plain x-ray. This is a nice entry point. And if on the contrast examination, the nuclear medicine study, yeah, fits your clinical picture. The x-rays were normal. The conclusion is probably a calcaneal stress fracture. You either wear the boot for the next 2 weeks or stop your activities or your pain's going to get worse. Me being the non-belligerent, very cooperative individual who never gets upset or angry, I will say, I'll do exactly as you say. Namaste. Okay? So that's how the bone scan works. in the child, or before we say that, is there are normals and normal variants in this world. There's radiopharmaceutical in the SI joints, those are normal. There is radiopharmaceutical in the growth plates, those are normals in that world. So it takes a specialist to take a look at this image, okay, to decide that there's abnormality. There's also gathering of the radiopharmaceutical in the bladder, okay, so on this image, there's radiopharmaceutical in the SI joints. There's also in the, a little bit in the bladder, but there's a particular hotspot, more of a hotspot on the reading left side compared to the right side. So if they found that, they would go back and get plain films to make sure there's no lesion or disease process in the greater trochanter of that particular individual. That's how the tool works. The bone scan or the nuclear medicine study. The numbers you need to remember. On a nuclear medicine study, they can pick up bone loss in the order of 3 to 5%. Our plain film, 30 to 50% of the bone in the lesion has to be lost before we can see. Meaning, what's your limitation? 1 centimeter because of these 2 rules. You just can't see small things, and you can't see things if they're abnormal. The trabecular pattern. How can you tell whether the apple is rotten? You slice it and you see the brown. Can you do that before you slice into it? 30 to 50% of the bone has to be lost on plain film for you to see it. The nuclear medicine study is much more sensitive by an order of what, 10? Okay. 10 times. Okay, so in certain situations I need a bone scan. Why? Because every other examination was normal. Repetitive activity is a good example. The stress fracture is a nice example of its application. All right? Next one is a CT scan. And a CT scan, well, let's show you what it looks like. That's what it looks like. It looks like an MRI scanner. And you lay recumbent in here. This machine does a lot of gyrations around you, and it captures data. Okay? Now, in the CT world, 64 slices better than 32 slices. More slices, more information can be gathered. All right? Very little radiation. So put a star beside this. The bigger number is better than the smaller number. All right? And it comes in 2 subgroups, a bone window and a soft tissue window, and we'll talk about that shortly. It's good for the bone soft tissue interface. What does that mean? Oops, here's my femur. This is the medullary cavity. This is the cortex. Adjacent to the cortex, when you get kicked in the shin, what do they call that? Painful shin. Good. They call it a bone bruise. So this area adjacent to the cortex that has potential is what the CT scan is good for, meaning it establishes the presence or the absence of disease where the wiggly mark is. Something called periosteal new bone formation. This is just the intro, okay? It helps us with directional growth. In other words, if I have a growth in my inguinal region, I don't know on plain film whether it's anterior, posterior, medial, or lateral. CT scan gives us all of those axes, okay? Tight joints. SI joint is an example of a tight joint. SI joint is another example of a tight joint. It's a small joint, very compact, and it can be imaged with a CT scan. Rough price, well, I'm thinking of it, $500 for this example. Okay, that's to the insurance company. I know if you pay cash, you'll get it for less. Okay, compared to $1,000 for the MRI. In Miami, I'm told you can get a lumbar spine MRI for $250 cash. We're not talking about that, we're talking about the insurance company. All right, so the numbers relate to the insurance company. The next thing is, this is unique to a CT scan, this scale. Minus 1,000 is air, positive 1,000 is bone. So when they if they did a CT scan of my trapezius muscle, they would notice that I have something on my trapezius muscle that was, you could wiggle it. It was soft. It was not on top, it was on, subcutaneous was on top of the trap muscle. What do you think it was? Besides the soft movable lesion.
Hematoma.
Hematoma, good. What if I told you it was filled with fat? Lipoma. So when they do a CT scan, they've taken a CT scan of my shoulder, they notice that you have a lesion in your traps, above your traps region, and it has this Hounsfield unit, whatever it is, let's say it's 30. Looks like a hematoma, lipoma. CT Hounsfield scale tells us it's filled with fat. It probably is a lipoma. I showed it to my dermatologist, he says lipoma. I finally had it out, okay? Interestingly enough, he said, this is one of those easy ones, it just create an incision and it basically squirts out like you squeezing the pimple. And for those of you that like the pimple popper doctor, that's not what it was like.
Oh, I
It
love
took
it.
an awful lot of pressure to get that thing out. He's saying it's a good thing it wasn't interdigitated with muscle tissue, connective tissue, because then you have to dig deeper and try to get all that separated, okay? So it has the Hounsfield scale, and this is only used with CT scanning. MRI has its own terminology. So important to know, they can measure fat, they can measure blood, they can measure whatever. It is very good for chest lesions and abdominal lesions. So if you have the possibility of you present with hematuria and they want to evaluate your kidneys, you're probably going to get a CT scan. Okay? This is MSK application. So back to my lipoma, he said halfway through, he said, can you lift your arm up? Did you abduct? Yes. And I'm thinking, all right, why do you do that? Spinal accessory nerve runs in the same area. I want to make sure I don't slice it. Thank you for being as detailed as you are. And at the end, he stuck a little bit of it into a tube and it got sent out for what? Biopsy. 2 weeks later, I get a report, a call, it's a non-aggressive lipoma. That's what they have to do. When we have disease processes or x-ray findings that we are abnormal, we have to decide which tool to use to decide whether this is aggressive or non-aggressive. Positioning of the spine and the extremities is the easy part. 7 and 8 is the hard part, where you have to make clinical decisions based on your knowledge and your evaluation of the x-ray. We're asking you to think and make decisions. If you're not used to that, this becomes a level above that. Okay, it's not just information retrieval, it's application. All right, so we can use this tool when it's appropriate. So for our purposes, tight joints, XYZ axis, bone soft tissue interface, chest, and lung. Diagnostic ultrasound for the list that we previously gave you. Okay? Now, in semester 7, we talk about all these things. Are you going to have patients who have discectomies? Say yes. Laminectomies, disc replacement intervention, fusions, yes. Okay? Are you going to have patients who have SI joint pain? The model here is ankylosing spondylitis. What's ankylosing spondylitis? Disease of the SI joints. Teenagers, let's say 15 to 20-year-olds, they have back pain for 3 or 4 months. You do your lumbar spine x-ray, nothing. AP lumbosacral spot x-ray, nothing. The next decision is CT or MRI. Ankylosing spondylitis, $500 exam versus MRI. Money is no object. You default to MRI. It's a good place to think about an ankylosing CT scan. We'll develop that in semester 8. Aneurysms, we talked about that earlier. This patient that we saw, first of all, is going to get contrast pre and post. And they're going to have a vascular surgeon ready, and they're going to do CT scan of the abdomen. Okay? So that's the application. What's DDH? Developmental dysplasia of the hip. We can do diagnostic ultrasound, okay? But if this hip doesn't develop normally, we can use diagnostic ultrasound in the hospital, okay? If your plain films show abnormality, you can then have a CT scan done. Why? Because the CT scan will help us evaluate the labrum, the covering of the femoral head, okay? My sister had, unbeknownst to any of us, okay, DDH. She had never had any reason to be x-rayed. I saw her one time when I was working in Phoenix doing a lecture, and she said, I've got hip pain. Tell me about it. It feels like there's glass in there. That was in April. Okay, they finally took some x-rays in Canada, and I saw her in April. She was headed for a hip replacement, And in the interim, between April and July, let's say, she had plain films done and MRI, and her labrum was totally destroyed, macerated. Okay? Now, you can say, why didn't you detect that earlier? She didn't have any pain. She had a normal upbringing. She had a normal life. She played high school basketball. She was a runner. No symptoms until it feels like glass in there. Okay? And the MRI confirmed that. So not every case of developmental dysplasia is going to be detected at the hospital. Here at the hospital, before you're released, you do internal and external rolling. And if the nurse who's done this 1,000 times says there's abnormality, they do an ultrasound. If you're in a small town, that may be the only thing that's available to you. Why? Because it's easy to have a portable unit, and then they can send the images where they need to send the images. Look, when my sister was born, today's her birthday, 66 years ago, they didn't have MRI. If they didn't do the hip rolling in Europe or wherever, how would it get detected? It only became symptomatic when I saw her in females. Okay, so you're going to see the effects of the prostatic surgery or the lump removed from the breast. Okay? What does tarsal coalition mean? Some bones in the foot are fused. Coalition is failure of normal separation. Degenerative stenosis means your spinal canal isn't the normal size. And it's being encroached upon from either the disc or the facets, some degenerative process around the spinal canal. And they can measure that because they can give you X, Y, Z axis. That's what the tool is. Okay, sorry. They're the same basic equipment. All right, it's either a CT scanner or a bone scanner. I mean, a MRI scanner. The big thing here is that's what one example of one looks like. $500 here, and it's only easy because it's easy to remember. $1,000 for this exam. Now, a shoulder X-ray, a shoulder MRI is not going to be $1,000. Maybe $250, $500. I don't know. Depends on where. And
yeah, it still costs me $500.
500. Yep, through the insurance, we get cash price. Okay. So it does factor into it. All right. So it's always, I saw something on the plain film. Do I use this? And do I use this? Money's not supposed to get into this whole equation. You're doing what's best for the patient. Okay? All right. This is what it looks like. Now, the reason I can say with confidence is this is a bone window. You're not seeing any morphology of the cord. So on our rectangles, these are the vertebral bodies. Is there a difference between this one and this one?
Yes.
Yes, the inferior end plate is eroded. What's between the inferior end plate of the vertebral body and the superior one below? The disc.
Yes, please.
This patient, if they had discectomy, they have infection in their disc. Are they supposed to have infection in their disc?
No.
No. So this is discitis or spondylitis. It shows up very well, but it doesn't tell us about is there or is there not involvement of the spinal canal region. So then they go to the soft tissue window, and on the soft tissue window they can make better decisions. They don't do bone window first. You lay in the scanner for half an hour, and all this information gets gathered, and then they can give us the data sets that emphasize bone because we can see the trabecular pattern, the sagittal orientation. Which orientation is this? Transverse or axial. So I can slice the loaf of bread this way, or front to back. It's like a loaf of bread, all right? So on our axial image where the arrow is pointing to, this whole entire aspect of the vertebral body has been eroded, okay? A better example, a normal vertebral body, this one is triangular, yes? Okay, now tubercular spondylitis, big discussion about tuberculosis, all right? No, before all of this happened, someone had a chest x-ray. Who gets tuberculosis? People in West Palm Beach or people in third world countries?
Third world countries.
Third world countries, how do they get here? Miami. Bus, walk over the border, whatever. Okay, before all of this happened, they would have had a chest x-ray or a skin sensitivity test. Those are expensive, okay? By the time they get this, I'm just using this to show you how much information they can get. The inside of the vertebral body is like cottage cheese, and that gets compressed, okay? And they get the classic gibbous deformity that's pretty consistent with tubercular spondylitis. That's end stage, My mom, when she was younger, she had a kidney removed because there was TB in it. She lived perfectly fine with only one kidney. I'm using this to show you it goes through its processes from inhalation, okay, and then you can do the skin test or you can do the chest x-ray. When it gets to this, it's very late in the disease process. You see this, your first reaction would be, say, it's a compression fracture. Wait a minute. The patient says, I didn't have trauma. That doesn't fit. They do a CT scan, normal rectangle, this is the vertebral body, but we now notice that there is a radiolucency or a dark area inside the vertebral body. That's not a good sign. That means there's gas inside the vertebral body where there shouldn't be gas. Then we do an MRI. Normal rectangle, this vertebral body is still collapsed, but if you make your device bigger, can you see this big, huge soft tissue mass?
Mm-hmm.
It's indenting the cord, yes?
Yep.
Okay, that's mass effect. So whatever's inside the vertebral body is now leaking into or causing mass effect in the cord. And if it's inside the vertebral body, it can seep through the little holes in the vertebral body and seep into your prevertebral fascia. And if it's in the prevertebral fascia, it can get into your abdomen. You want Mycobacteria tuberculosis in your belly?
No.
So they are able to tell that. This is the starting point. This looks like old TB. We need further investigation. Where are the clinical records, the chest exam, all that good stuff? But no, we're worried about the gas, we're worried about the mass effect, and on our axial image or transverse image, we need to get this treated with the appropriate cocktail so that we don't get a acute abdomen. Shows you all the utility of CT scanning and MRI. Okay, do I do this to every patient who has TB? No, only the ones that have chronic thoracolumbar pain. Where's the chest x-ray? All right? Why is that? There was supposed to be MRI. You're lucky. No MRI. I think I divided it into sections. Questions on the imaging so far? So the next big step is MRI. We'll probably do that when we do, we'll divide it into cervical, thoracic, and lumbar. So the last and the most expensive utility is MRI. Now when you hear the words T1 and T2 weighted images, those terms, that's MR world only. CT language is the Hounsfield units, bone and soft tissue window. And we're gonna keep going on that scaffold and accelerate and add to it so that you make good clinical decisions when you've got 2 minutes on the national board case. 2 minutes goes quickly if you're like a deer in the headlights. But if you're rational and calm about your search pattern and you go through it, the answer has to be there, okay? And usually what they do is a plain film on this side, this and this. And they'll say, abnormality here, pancake vertebrae or a collapsed vertebral body. Is there mass effect on the cord? Well, at that point you have to be clever enough to see that. Could be as simple as that. I can't predict what they're going to ask. But the basic approach is the same, okay? And we keep working with that so that everybody will feel more comfortable by the time they get to semester 8. By the time you get to semester 8, enough talk to you already. Okay? You're not supposed to be I can't think of anything worse than mini DA CBRs, robotic people running around talking like me. Okay? That's where we're headed. But you want to get through your exams, but you also want to make good clinical decisions when you're in clinical practice. Fair enough? Okay.